sir. We can see you, Dr. Raj. Go ahead.
Okay, terrific. So Akriti is going to go ahead and present our second case. Tarun, can you quickly go ahead and introduce our team? To my left is Tarun, Jubin is right here, Akriti is our fellow. Can you introduce the rest of the people in the room, please? Yeah.
So we have, thanks for coming in early. So George, Terry, Liza, and Abby from the cath lab, and of course Dr. Makkar, who's a magician with echocardiography for mitral clip, and we have Rachel from Abbott, who's here to support the case. And without further delay, we can get started.
So this is a 64-year-old gentleman, history of coronary disease, status post multiple PCI, 3-vessel cabbage. He has ischemic cardiomyopathy. His EF is 30%. He has functional MR, and he has presented with several recent hospitalizations for decompensated heart failure, despite being on optimal medical therapy. Next slide. The transthoracic echo here shows restricted leaflets. The posterior is more restricted than the anterior, and there's severe MR. The jet is directed posteriorly. Next slide. Next slide. And these are the TE pictures, which we're going to see live now as well. So I won't waste much time here. Next slide. So essentially, severe symptomatic functional MR, despite optimal guideline-directed medical therapy, NYHA class 3, and we're going to go ahead and do edge-to-edge repair.
Okay, so terrific. So I think that what we want to do is, first of all, if you can show the hemodynamics there, look at the left atrial pressure. The V waves are huge, right? Or they, so they're quite tall. They were actually a little bit taller earlier. So, and we want to show you the transeptal puncture. Can you, and I love this new VersaCross transeptal system. I don't know if you guys have adopted this in your lab, but as we were doing this earlier, we took some fluoroscopic images, but it's a system with a pre-shaped wire, and you're using electricity to sort of cut through. And you see that. So, and to the right, you're looking at the echo pictures. So what, there's a bicable view and the short axis view. And this is a pre-shaped wire. So you go ahead and dilate with the system, the sheath and the dilator, all right? And you are seeing the indentation on the right on the echo, all right? So getting the proper height is very important to actually be able to do this procedure. So now you don't have to do wire exchanges over this wire. You can advance the guide of the MitraClip system. So this is the guide that was advanced and, into the left atrium. Are things clear in terms of the steps so far?
So, Raj, the one step that I think it's critical for people who are new to the technology is the height piece of this. I don't know if I saw a measurement of that, but maybe 15 seconds on what height are you targeting and why that's important.
So if you look at the echo picture now, which is on the screen, what Moody did for us was, as we were, creating an indentation on the septum, he's given us the measurement of the height, and if you look at it on the left side, the distance was 4.38. So we like to be above 4 when we are doing these cases. And in fact, occasionally when you are doing cases with big flails, you may decide to be even a little bit higher. So I think a minimum of 4 is what we like. Otherwise, you have to do some advanced maneuvers to sort of gain height. So Moody, can you tell us very quickly in a couple of minutes, you can show us some home shots, and tell us about what you found and what our strategy is?
So as you see here, it's a typical classic functional MR with a severe, jet in the middle. What we found here is that we go directly to the BICOM LVOT view. It should be playing here. And then we started to look at the anatomy of the valve. And as you can see, it's restricted with leaflets, both. And then we measured the length of the posterior leaflet, and it was 1.63. It's important because it helps us in making the decision between XT versus NT, which clip should be used in these patients. In general, for functional MR, we'd like to use NTs. And then for degenerative MR, we like to use XT with a longer clip arm. But in this situation, we found the leaflets are so long, and the leaflets are in this, good quality, thickened, that we felt that if using XT in this patient, it will be more beneficial by reducing more of the EROA that can happen with it.
Yeah.
And you can see here, this is the BICOM LVOT with the color.
Yeah. Okay,
And
great. So
then
this is
the
the
3D of the valve, and
Yeah.
then this is here the color jet, where it's coming from. And then this is the mean gradient we got. It was about 1. And then we got the veins. I'll show it just quickly here so we can follow it up during the case. It was 1, the left side was blunted and the right side was reversed.
So I think fairly convincing different pieces of information here in terms of severity of MR, right? There is no doubt that this is a, the LV function is not, it is bad, but it is not so bad. They talk about the proportion of MR in comparison to the LV dysfunction. And this certainly fits the bill for the coapt patient, which is where the benefit in mortality and rehospitalization and delaying heart transplant actually was clearly demonstrated all the way up to 3 years. So, okay, so what we have now is we decided to choose the XT, and, our thought is that we're going to take an XT and deploy it in the middle and see what happens. And perhaps we'll end up deploying NT clips next to each other. So we will go and we will be with you till you have time.
3D steering, please.
All right, so we will go ahead and now give some M and bring this clip down. We just need to make sure that we are not touching something and we are in the LV, in the left atrial cavity. All right, so we are flexing, we are putting what is called the M knob. All right, and also before, this is, I'm making even before I open the clip, we know from fluoroscopic understanding that this is the way, the clip needs to look for it to be in proper position. All right, so I think that, Moody, what would you say? You think?
Yeah, looks good. So one of the things that we started to use more of the technology is the NPR,
Yes.
which is the life multiplane reconstruction that it guides us a lot during the procedure about how to orient us to have a good trajectory in these patients and how to get proper positioning. It saves a lot of time and makes it more accurate to do that. So
Moody, do you think we need to advance and give a little bit more of M?
exactly, yeah. So
All right, so
this is the BICOM view here, and this is the LVOT. And as you see, the trajectory would like to be across this red line. You can see that here it is diving from medial to lateral, and we need to fix that.
Yeah. Okay. Now, and what do you think about our trajectory in the, in your LVOT view?
And the LVOT view, you can look at it here. It looks reasonable here.
Okay.
It's almost perpendicular to the coaptation line.
All right. So I think, if it was an aorta hugger, then you would give plus, and you would have to take off some M, but it seems like we are not bad. The question is, do you want us to give a little bit more M?
Yes, I'd like to give a little bit more M to make it more perpendicular. Yeah.
All right.
So here.
Okay. Okay, so, the person who's manipulating the guide and helping you make coaxial is a very important person. So Tarun is making all these movements, going anterior, posterior. All of those things are very, very important. So, okay, so what we'll do is we'll raise the grippers here. We will unlock the clip. If you agree, we will open. We don't have a lot of height. Okay, so
you can come back.
Oh, we do actually. Okay, so we do. That's great. Okay, so which makes me happier. In case we need to come out or something, we'll be in a better position. So we will go ahead and open the clip. All right. So even before we opened, fluoroscopically, we knew what to look like, so that when we open the clip, as you can see in the right lower panel, that we are a little bit clockwise, right? But we are not very much off though. So we will go ahead. Moody, do you agree that we need to?
Yes, exactly.
To counterclock it.
Again, one of the fun right here is that you're going to find this is the coaptation line, and you want to be perpendicular to it. So what I do is I'm going to bring it up here across it, the clip, and you can see that needs a little bit, and then
so we need to push the whole system
a little bit more,
right.
Towards,
so I think that's a better option than taking medial off, because we want to be on top of the valve. So yeah, so
a little over count.
Okay, so Tarun thinks that we are a little over counterclocked. So I will go and clock it a little bit and also it's important that you take out the tension out of the system by going back and forth. So when you go below the valve, you don't know how to quickly turn. Okay, so now Jubin is going to go ahead and test the grippers. So you see the grippers on the upper right panel, Saurabh and Duane, are you able to see that?
Yeah, and it's beautiful images first, and then great job at doing those micro steps. So I think these grippers are really important with the newer generation mitral devices with the clip, right, to show which gripper is what.
Okay, all right. So so we are going to, if you agree, we will cross here unless you want us to move a little bit more. I think we are fairly in the middle. What do you think?
I think so, and then we can put the color and add it. And I think it's
would you like us
where
to
we want to be.
Would you like us to cross?
Yep.
Okay, so we are going to cross.
And you can see here as you're crossing, the clip counter rotated a little bit.
Yeah, so that is not uncommon for it to rotate a little bit because, you know, I think we still are not always successful in completely removing the stored torque or tension. Okay, so the question is, are we still happy with the position in terms of, and then of course,
and so we'll let's go and check. I'll check that here. And so we're going to go to the BICOM LVOT to check that and to make sure that we are still in the appropriate plane.
Yeah.
And then,
you know, for some of the new operators, you know, XT is a longer clip compared to NT, which is a little bit shorter. And then, of course, there is the NT regular and the wide and the same thing. So 4 millimeter versus 6 millimeter width. Okay, so, you know, so Tarun is basically helping.
So I think we are posterior leaflet is, I think we're buckling.
Okay, so do you think, Moody, we have posterior or you think we're buckling?
No, we're buckling it here. And I think we're a little bit more medial than we'd like to, you know, be. I think it dived a little bit.
So the question is, should we take just a tiny M off?
Yep, I agree.
Tiny M off. And then we can push it in a little bit if we need to. The question is there a chord there? And we chose a W, you know, and this is what I don't like about the W, because you can often run into chords and then you're struggling compared to the regular XT, which is only 4 millimeters. And I see that we are just hitting the chord.
If we go a little deeper and come up, right?
Okay,
so let's check the orientation before we go down here. So make sure that we have perfect orientation.
Now, you know, when the XT came out, first, we were just simply very, very enthusiastic about it. And we used it in almost every patient with functional MR. And then what we saw was that in patients that have really thin leaflets, you know, functional MR, very dilated LVs, we saw some micro tears in the leaflets. So we sort of backed away from using because I think you put a lot of tension on the, all right. So I think as you can see, we are hitting the chord. So what would you like?
A little deeper, I'll dive it posterior and then we'll come up.
All right.
Okay, now if you come up. Okay, I think now we have.
Okay, so now we have it probably.
Yeah.
But we don't
have the posterior.
Yeah, we have the posterior.
Let me get you a good view in a second here.
Because I'll swing anterior to get the anterior.
So that's a good maneuver that we use fairly often. Can you describe that, Tarun, for the audience on what you just did, which is to come up and then rotate anteriorly, right?
So, you know, the cord is hitting the posterior clip arm. So you have to get away from that cord. So you push it deeper. So you go below the attachment point of cord to the muscle and then go dive a little posterior and come up. And then you are able to, okay.
All right. So, you know, I think, Moody, would you like us to independently capture? I'm not happy with the posterior either, even now.
See, now it's again buckling.
Okay, so now it's buckling again, you know, so I think we may also have rotated the clip a little bit. So can you please
check the orientation? Okay, I'll check the orientation.
Yeah.
Raj, do you typically find that opening the clip a bit less wider here might help that posterior leaflet go down into the V a little better?
Yeah. I mean, I think we try different things. Yeah. So I think I'm going to do a little counter, just a little counter
here.
Okay.
Still in a good position here, color-wise.
No, we don't have either. I think we should pick a different location.
Okay, so I guess what we will do is, because maybe we can come back here, and so our plan of putting a wide clip in the middle, we may have to change this.
Yeah.
Okay, so let's just go ahead. And what would you like to do? Push in a little bit? Can you show us some color?
Moody,
Yeah.
let's find a different spot.
Okay, so let's just
Sure.
do this.
So I think it's a little bit even worse on the lateral part. So
Okay,
you push in a little bit, it might get better.
Do we have posterior?
As
So I
you
think
see
let's
here,
grasp
it's clear that you
posterior.
have it.
okay, now go anterior, please. And we'll do what Saurabh said. So we'll close the clip a little bit and see if that, can you go more anterior, please?
Going. Okay. We lift it. I think we have it. If you lift more, we'll.
Do we have it?
Let me check it here. Yeah, you have it here.
So I just lowered the gripper. Let's make sure that we have enough and that we are not rotated.
So maybe, you know, you can start pull it up a little bit, optimize the anterior.
Yes, we need to optimize the anterior was what, Polka? Okay.
Unlike TAVR, during this procedure is totally dependent on echo guidance, it looks, because
Absolutely.
Yeah, You're
I
right,
think that-
Dr. Srinivas is, you know, kind of term it that TAVR is like bowling.
Huh?
You want to do it
Posterior
the
may
same
slip out, let's
time,
close.
same way each time. But MitraClip is like golf. You need to
Okay, so
like use
Moody,
a
what
different
do you
club,
think?
change things.
I would
know?
still try to optimize the, you know, so, you know, I'll try to pull up a little bit and then optimize so you can have more leaflet insertion.
Okay, all right. So we will start with, what would you like us to optimize first?
Moody anterior.
Anterior first, yeah.
Anterior was?
Polka.
Okay, so we'll come up a little bit and lower it. What do you think, Moody?
Let me check the clip orientation last time here. Because many times during all these maneuvers, the clip rotates by itself, and then we can cause some distortion of the valve here.
So I think that our clip is rotated.
Yeah.
A little bit, right?
Yeah.
So
you can
what
see.
we have to do is we have to raise both grippers. Okay. So if you can go to 2D, please.
You want to just to raise anterior and turn a little.
Okay. So I think Tarun has a good point. We can just, okay. So can you, what do we need to do? We need to do a little counter.
Yeah.
Yes.
Okay. So we will go ahead and raise the anterior. Can you raise the anterior, please, while I do this? Okay. So I will do a little counter. Okay.
Let's check it with 3D.
Yeah.
Lower it, huh?
Yeah, Moody, go to 3D.
Don't lose it. Lower the gripper. Yeah.
Still needs to move a little bit.
Okay. So we will do a little bit more.
Raise the gripper anterior.
All right.
Okay, that looks very good here.
Okay. Let's lower it now. And can you tell us, confirm that you have what you need?
I think it looks good. One of the good assuring signs that you can see the grippers are
Yeah.
moving up and down.
Yeah. But do you think we have a little medial dive, or do you think we are okay?
I think we're okay here.
Okay.
Uh,
Would you like us to close and see what happens?
or you would like to optimize the posterior a little bit more
Okay. So,
because we have a lot of length of the posterior leaflet here.
So
as
I'll
you
go.
see.
okay.
I'll
So
go
can you,
posterior first.
okay. So can you go, can you go towards
Yeah,
posterior?
yeah, I'm slowly going
Okay.
posterior.
Go.
Okay.
I think we have a little bit more.
Yeah.
Yeah. Okay, so would you like us to close? You
Sure,
put
we can
color
start
and
closing
let's see what
and see.
happens. So we are slowly closing. This is an important step where you don't go too fast and make sure that in this case, we are not above the annulus that much. So I think that, you know, because that is where you can have leaflet tears, you know. So I think you can see as we are closing the clip, you can
MR.
see actually what has happened to the mitral regurgitation, right? So I think, all right, and yeah, do you see that?
That looks wonderful.
Right?
Amazing.
So I think, yeah, so I think, we still have small jets, but I think it's clearly, I think we have significantly reduced the mitral regurgitation with our first clip, and I think we should show the left atrial pressures. Are you able to see the left atrial pressures?
Yes.
All right, so you can see how the left atrial, the V wave has now, some of this is of
Wow,
course,
it's amazing.
some of this is damping from the, but
damped,
even with the catheter in, the V waves were actually, when we first came to you, the V waves were much, much higher, as you remember. I think the V wave was what, 38 or something, 38, 40. So it's now down significantly. Okay. So what we will do is we will go ahead and release this clip. We will reassess. And then what Moody is doing is Moody is showing us the pulmonic vein flow. Moody, why don't you tell us what exactly you're looking at?
Moody, you're happy with the grasp, right?
Yeah, I'm happy with the grasp.
Okay,
So
why don't we release this? And
Yeah, go ahead, Julie.
Take a picture with the balloon in so that you can see for length.
And you can see one of the signs that we see here. So what we do here is that we're going to go and check the leaflet insertion, which was very adequate. Here, we're going to go and, as you see here, and then we're going to go and check a 3D view of that. And you can see there's a nice bridge with a very good orientation. And I turn it again down, and then I increase it up. And then I add the color to it to see amount of residual MR, which is very, very minimum.
Yeah.
Then we get the two hemodynamic measurements looking for the, and then you see there's even, smoke
in the left
here
atrium,
in the left
right?
atrium, which is a very sign. Yeah, exactly.
Yeah.
I don't know if your screen resolution can show that or not, but you can see definitely it's a stagnant flow there. And then we check the gradient and we check the pulmonary veins after that to make sure that we didn't have any stenosis, and that pulmonary veins is one of the very good indicators for successful reduction of the MR, despite having some residual color, as you can see it. So,
okay.
Sir, great demonstration, sir. Both pressure-wise, echo-wise, excellent demonstration. Thank you. We are slightly running behind, sir. Can you show the?
Sure. Yeah. So that's fine. We thoroughly enjoyed, transmitting our cases to you. So thank you for the opportunity, and I want to wish everyone really well.
No, sir, we are extremely thankful to you for excellent demonstration and cooperating in these tough times.
Yeah, we had a double valve in-valve case, mitral valve in-valve and tricuspid valve in-valve, which the patient became unstable, so we had to do it urgently over the weekend. So we couldn't show you,
sir. This is good. This is in fact good for us because we could see this also from your expertise. Thank you, sir. Thanks. Okay. Excellent demonstration. Terrific. I appreciate all the live transmission technology which is done, sir. Thank you.
Terrific.
Thank you. Thank you, Raj.
Thank you, Duane and Saurabh, for excellent moderation of this case.
Dear friends, greetings from Fax Foundation, TCT India South Asia 2021. This video brings to you live case learnings from Dr. Raj Makkar's case of Mitra clip demonstration. This was a ischemic cardiomyopathy type of situation with severe functional mitral regurgitation. Surgery was done before, and then multiple cardiac interventions, procedure revascularization was done before. Now this is being done to tackle the mitral regurgitation in this patient. Then what we have learned is how to assess the MR, whether it is ischemic or degeneration, effectively by transesophageal echo, and also 3D echo demonstration was excellently shown how the valves degenerate and how the posterior mitral leaflet was restricted, and how the anterior mitral leaflet were prolapsing a little, and all these combinations were leading to physiological MR in this patient. And then other important aspect point which we learned is the technique of Transseptal Puncture, especially how it is different from regular Transseptal Puncture what we used to do. before is this Versa cross system, which is basically connected with electricity generated wire, he said. Probably we also have seen the RF energy generated systems also before. Versa cross system, and effectively focally identified a point of puncture, again on the TE guidance, and the short axis view which was projected, and how the indentation was seen from the annulus, and the minimum width which should be there before between the puncture site and the annulus felt was 4 centimeters. And this here in this patient, it was done at 4.6 centimeters, and then that's how the valve crossing should be a problem. So this way it is a very effective and confident transeptal puncture was shown without any problems of getting into tamponade situations. And we also became wiser with this case. They went to use NT and went to use XT type of Mitra clips. And he highlighted that in functional type of mitral regurgitations, usage of NT clips could be okay, whereas degenerative mitral regurgitations with more of floppy and more of degenerated valve leaflets, probably XT type of Mitra clip, which has a little longer length, could be preferred. And there again, each of these NT and XT devices could have a normal sized one, which is 4 mm in width, and the wider one, which is 6 mm in width. And this patient, it was effectively closed by using one XT device. And the effective demonstration of this direction of mitral regurgitation was shown with the progressive tightening of the Mitra clip, which was very well demonstrated by transeptal echo and 3D echocardiogram pictures. And most of the procedure, what we've learned in the Mitra clip procedure is based on the transesophageal echo guidance. So it is very important for all of us to develop a good echocardiography team, and with proper imaging facilities and better machines where we could effectively see the color, and then the 3D echocardiogram to show effectively how the Mitra clip is seated, and how to avoid the caudal entanglement in the clip, and how we can effectively demonstrate the regurgitation of mitral regurgitation with the clip, were all demonstrated mostly by echo guidance. Now finally, in this patient, single clip could abolish the MR totally, and then it was all effectively shown within 30 minutes time allotted for this live case. So thus we all learned how transeptal puncture is different in this, and various types of clips available, and how we need to select which clip for what. And finally we saw an effective reduction of mitral regurgitation, and LA pressure, which was about 40 plus immediately after the clip was implanted, it decreased again to significantly to about 15 mm, which was again effectively shown by proper hemodynamic monitoring. Hope you all enjoyed this live case transmission of Dr. Raj Makkar and the live case learnings, which we try to simplify and get it to all of you. Thank you again for making TCT India a grand success, and thank you all.